It's
Like,
Friday.
comment, and subscribe.
It's Friday.
Like,
So
comment,
welcome
and
back
subscribe.
to the multiple sclerosis
Like,
channel.
comment, and subscribe. Like, comment, and subscribe. Like, comment, and subscribe.
Hi everyone, Dr. Sam here. I am an MS neurologist living with MS, and today I wanted to talk about progressive multiple sclerosis. So progressive MS comes in two varieties. There's primary progressive, which is when people will have symptoms from the beginning and never really return back to their normal or their baseline. And then the other type of progressive MS is called secondary progressive MS. And this is the type of disease that develops after years of living with relapsing remitting MS. This is a nice diagram. It shows the transition kind of from an earlier stage on the left-hand side where somebody's relapsing, kind of has a lot of symptoms and then comes back down to close to normal, and then over time has more and more symptoms. And so that's, as the line is going up, that's higher disability or more symptoms. And sometimes this is or isn't related to relapses or new spots on the MRI, which are the little arrows on this diagram. We're still trying to figure out entirely what underlies progression, and there's some evidence and a few theories. So in relapsing MS, the inflammation is systemic. It's in the bloodstream, in the circulation, and it gets into the brain when there's inflammation that kind of breaks down the barrier between the blood and the brain and allows those inflammatory cells to get into the brain and cause a lesion. When you're talking about secondary progressive MS and people who are getting worse with symptoms that are worsening, even though they're not having relapses, at this point, the inflammation has become localized within the brain itself. And this is also why it makes secondary progressive MS or progressive MS in general really difficult to treat, because a lot of the medications or all of the medications on the market today really affect how your immune system works systemically, how the cells are working in the blood and they don't get into the brain. And this is why the medications we have aren't very effective at progressive MS, but they are more useful in relapsing forms of MS. There have been autopsy studies where, researchers take the brains of people with MS who have passed away and they look at the lesions under a microscope, and they can see that a portion of the lesions are actually still active in people with progressive MS with inflammatory cells kind of around the edge. Some of these lesions increase in size over time. And this has led to kind of a phrase that we are using now in the field called smoldering inflammation or smoldering MS. And there's a lot of research looking into how do you attack this and how do you stop this from happening. The reason there's a lot of excitement about the BTK inhibitor class of medications that are being researched right now and probably will be on the market in a few years is that they actually do get into the brain. And so there are studies right now trying to see how effective those are and whether there's any effect on the progressive forms of MS because they're able to get into the brain where other medications don't. Besides ongoing inflammation within the brain itself causing worsening symptoms in progressive MS, there's also this theory, I have this up here, it's called the topographical model of MS. And basically it says that, you're accruing lesions with the relapsing form of MS, and sometimes you have symptoms from these lesions, sometimes you don't. And when you're younger, you are able to compensate better, especially for lesions in the brain, which can be very often asymptomatic. But those lesions are still there. And as everybody ages, kind of the ability to function normally declines. Everyone slows down as they age. And so what this model shows is that kind of, if you imagine you're in a pool and you have a shallow end and a deep end, and as you age, the level of the pool goes down slowly over time. That's kind of your functional reserve, like how quickly you're moving, how well your body's working. And so your body can compensate pretty well when that water level is high. You can have some spots in the deep end and they're never going to come across over the surface. If you have a lesion in kind of the more shallow end, you might have symptoms that kind of peaks above the surface and you see those, you see evidence of that lesion. And this is more typical with spinal cord lesions. You can see, which is listed in the red along the bottom x-axis, then brainstem, cerebellum in the yellow, and then the rest of the brain is in the green because that's where you can hide a lot of asymptomatic lesions. So lesions that are in the spinal cord and in the brainstem, more likely to stick above the surface and you're actually going to have symptoms, but sometimes they don't. And what happens is those lesions are still there. Your body is compensating for that damage. And then as you age and your functional reserve declines, like it would even if you didn't have MS, all of a sudden now you're having symptoms from those lesions. Just to reiterate this again, so I zoomed in on the relapsing part of this diagram. In relapsing remitting MS, you might have some lesions that are under the surface of what we call the clinical threshold, where you have a spot in the brain or the spinal cord. We can see it on MRI, but it doesn't cause you any symptoms. And then as you age and the water in your pool or your clinical threshold and your functional reserve goes down, you start to see symptoms from these old lesions that happened when you were actually in the relapsing phase of the disease, but may have never caused you symptoms because your body was young and healthier and was able to compensate better. But as you lose the ability to compensate, those symptoms come out. And so it's not that you're having active disease at that point, but you're actually having symptoms from, disease activity years ago that's coming out in older age. We know from natural history studies before there were effective medications for MS that over 90% of people would reach the secondary progressive stage after 25 years living with MS. I'm actually looking and can't find any good numbers on the rates of progression on DMTs now that we have such effective medications compared to before there were effective medications. But I can tell you anecdotally, just seeing people in the clinic, people are accruing less disability, they're getting less lesions. Like I showed on the topographic model, when you get older, having less lesions, you're going to have less disability. And a lot of these medications aren't that old, so I know that going forward, we will be seeing less people going to the progressive stage. Now, there's still a lot we don't understand about progressive MS, and there is also theory that kind of the progression and the brain inflammation is kind of paralleling the systemic inflammation, and maybe we need to be targeting them both early, but it's really still unclear. It's also not clear why some people progress very rapidly or early on in their disease course while others do not, although as I've touched on in other videos, it's probably a combination of lifestyle factors, genetics, and environmental exposures. But this is really an active area of research, and hopefully, in the next decade or so, we'll better understand progressive MS like we do relapsing and have some more effective therapies.
The latest MS research, part 1. Everybody, I'm Dr. Michael Johnson. I'm a doctor of natural medicine, and I've been in private practice in Appleton, Wisconsin since 1983. And I'll start off by saying I was diagnosed with MS in 2009. And the MRI of the brain was inconclusive, so I'm a functional neurologist as well as a functional medicine doctor. And so I knew enough to do a visual evoked potential, a VEP. So the optic nerve is the first nerve to demyelinate, usually, and that's what they did. And the VEP showed that I had MS. So, no, I didn't go down the route of the medicines and all of that stuff. It just wasn't for me. It's not what I do. And so I've been taking care of myself throughout all these years. What have you been doing? Well, that's what we're going to discuss in this video series. Yeah. But first, we're going to talk about where all the latest research is. And the latest research has to do with mitochondria. Mitochondria are the powerhouses of your cells. They're the batteries inside the cell. Your brain has 5,000 per cell. So does your heart. And so you need to recharge that battery, but before you do that, you need to really remove toxins and infections to really have the most optimal effect. So we're going to start off by talking about VDAC. Have you heard of VDAC? If you have too much VDAC, you're going to end up with a neurological condition. Okay? A neurological condition like MS, Parkinson's, Alzheimer's. And if you have too little down here, you're going to end up with cancer. So VDAC is, I call it the Goldilocks of the body. And what is VDAC? It's voltage dependent anion channels. It has to do with the mitochondria. And here's the research. Now, if you go to pubmed.gov, you can find all of this research. Here's the first one. VDAC, a multifunctional mitochondrial protein regulating cell life and death. That's what it is. It's a multifunctional mitochondrial protein that regulates cell life and death. Mitochondrial VDAC, the key gatekeeper as a potential therapeutic target, and it is a therapeutic target, and it does work. And this is the latest research, and so let's get into a little bit of it. Here's one. The role of mitochondria in axonal degeneration and tissue repair. I almost said something else. I had to catch myself. Boop. That's Broca's speech area. Not working. Oh well. The role of mitochondria in axial degeneration and tissue repair in MS. There it is right there. Boop. This one, multiple sclerosis.
The best you can be. Love your family. Love your friends. Spread love. Not violence. Not this virus. As always, peace.
Comment and subscribe. Like, comment, and subscribe. Like, comment, and subscribe.